I now have the honor of presenting Dr. Jonathan Woodson, who is the Assistant Secretary of Defense for Health Affairs, who's going to talk about military medicine in regard to national security. So Dr. Woodson, welcome. Some water.
Okay, thanks. Great. Well, good morning, everyone. Oh, good morning, everyone. Great. It's wonderful to be here today to participate in this AMSUS conference. As Dr. Clancy has just laid out, and I'm glad she preceded me because it gives you an idea of how complex the healthcare and healthcare delivery environment is, particularly in the United States. But for our international guests, I'm sure you're grappling with many of the same issues around maturing your systems and delivering the appropriate care to individuals to improve the health of the beneficiaries that you serve. So it's a pleasure to be here today and talk about the issues that we are challenged with in the military health system, and to lay out for you what our strategic pathway is to getting to an end state that makes us better, more relevant for the future. As was said before, many of our healthcare systems, particularly in the federal space, have large and complex missions. The military health system is a system, a healthcare delivery system, of course, that is a strategic national defense asset and is in support of the national security strategy, national defense strategy, and national military strategies. And that must be understood. If you heard Dr. Clancy, and particularly for our international guests, you might be a little bit confused about the military health system and the veteran system. So in the United States, of course, we have a military health system, which, as I described, is a key component that is an enabler for our national defense strategy. And then, of course, we have the veteran system, which is responsible for the care of those individuals who transition to a non-active duty veteran status and accrue benefits by virtue of their service. And so I want our international guests to understand that divide, which may not be in place in other nations. I know is not in place in other nations. The next point before I get started really here is to understand the broad mission of the military health system. So again, we're a key enabler, we're a strategic asset for the national defense strategy, but we have a broad mission that includes running hospitals, clinics, hundreds of clinics, both in garrison and in deployed environments. We run a public health system. We run medical education and training systems, turning out some excess of 26,000 enlisted medical specialties every year. We have 217 graduate medical education programs. We run the TRICARE health benefit, which very much looks like an insurance product so that individuals who have served and accrue this benefit can actually have health care delivered in the private sector, and we pay for it. And then we run a complex research and development system that, in fact, produces the advances that allow us to do our job and deliver better care and save lives on into the future. So you need to understand all of that as background. Well, this is my agenda for today, and so I'm going to speak about military medicine in this complex environment. I always say in these forums that, when I was at the War College, we always talked about strategic leaders and them needing to understand the volatile, uncertain, complex, and ambiguous environment in which strategic leaders need to lead. This is very true of healthcare in America today and across the globe where we're deployed. So I'm going to talk about this complex environment from a national security environment, national health environment. But for our international delegates and our federal partners who are with us today, I want to assure you that these issues that we are confronting affect you in many ways as we talk about partners and our challenges. But once again, I think you'll see threads that tie back to your own systems. Our successes, we understand, will emerge when we collaborate better over many initiatives. This is our commitment in our view. This overview is about understanding the imperatives of our environment and the healthcare delivery issues of today and the pathways really to success. So let's begin with this slide here, which describes this chaotic national security environment. Unpredictability reigns. A year ago, we were discussing the issue of drawing down in Afghanistan. We were looking to a relative period of peace and non-kinetic activity. But who would have thought all of the events that have occurred over the last 6 months and throughout the summer? We have new issues with Russia and Ukraine. We have the growth of ISIL. We had the outbreak of Ebola. And the world just seemed to be on fire. What we realize now is that we're in a period of what others have called the long war. It may not always be marked by intense kinetic activity, but there's going to be activity around the world to which we're going to have to respond. And if you come back again to my basic premise at the beginning that we're a key enabler of the national security and defense strategies, we're going to be in demand. And sometimes we're going to be near the point of the spear, and sometimes we're going to be at the point of the spear, as in the case of Ebola, both domestically and internationally. In addition to the national security issues affecting military medicine, there are forces in American medicine that are radically changing, and Dr. Clancy outlined a number of them, the standards, but there is changing technology, changing specialties, and most importantly, there are changing expectations. I think one of the most important lessons I've learned over the last 10 years as I advanced in leadership and my connection with the military health system is that the expectations of our beneficiaries and more importantly the expectations of our national leaders are that the military health system will not just deliver the standard of care, because as Dr. Clancy already outlined, there are some real deficiencies in the standard in which we deliver care. Our national leaders expect us to deliver above the standard of care, no matter where in the world we are delivering that care, and our leaders expect us to close the gaps where we don't have knowledge about the strategies for care as rapidly as possible. And if you look at all of that has been written, all that has been stated from our national leaders about traumatic brain injury care, about post-traumatic stress disorders and other issues that we've been criticized on, it has been about the fact that we haven't closed those gaps. Not that we haven't met the standard of care, in some cases even exceeded the standard of care, but they expect us to more rapidly advance to ensuring that the right care is delivered in the right place at the right time. In addition, we have these other issues that are coming on board that will either directly or tangentially impact us. So the Affordable Care Act, which is our national effort to make sure that every individual is insured and has access to care, will put stress on us in terms of competition for providers and the like. And so we just need to understand that that's going to be out there and we're going to have to deal with it. There are other important federal, national issues of health that we need to deal with, such as the issue of obesity and tobacco use. And Captain Ellenberg outlined some of our strategy yesterday as it relates to reducing use of tobacco products. But One of the major reasons young people cannot enroll in the military, enlist in the military, is failure to meet height and weight standards. And so this becomes a national security issue for us, and we need to deal with it. Deal with it not only in concert with our other national federal partners, but deal with it within the ranks, because it's also the #1 reason or a contributing reason to the major disenrollment from the military, inability to meet height and weight standards. So a lot is operating in the national and international environment. Now, as we look to the future, we need to remind ourselves that we have done some remarkable things. And I'm going to state this, but with the understanding that we can't rest on our laurels. So over the last 13 years, in a period of continued kinetic activity, 13 years of war, we've made many advances. This slide indicates that despite the fact that we have seen more severely injured individuals, our survival rates and case fatality rates have fallen. And this is in the context of very austere environments, rapid transportation, strategic redeployment and transportation back, providing in-route care that is highly sophisticated with extraordinarily low loss of life. So that now, if an individual is injured on the battlefield today, and they are taken to one of our level 2, 3 centers, they can expect a 98% survival. This is unmatched in the history of warfare, unmatched in the civilian trauma centers, and we need to be proud of it. But again, I need to remind you that the expectations are even greater for us, and we cannot rest on our laurels. This also explains a dynamic process that goes on between military medicine and civilian medicine, in that during periods of war, we often advance our strategies for care, particularly as it relates to trauma casualties. And that information diffuses into the civilian population where during the interwar years it's advanced. This dynamic quality suggests that as we go forward, we need to ensure that we've got the right connections and partnerships to sustain our momentum as we advance care. This advertisement was not a military advertisement, but acknowledges that the techniques that have been developed on the battlefield in Iraq are serving the needs of people who are injured in the cities of the continental United States. Actually, this is a slide. Now, as we have gone forward in the spring of this year, federal health care was in the news a lot. Dr. Clancy has outlined some of the issues that were raised in the Veterans Health Administration, but the military health system was not immune to criticism or critical review as well. And the important thing to note is that this is appropriate. In our society, where we clearly have a free press, which is an important component of our society, we do need people, again, to examine what we do and to ask the correct questions about whether or not we're meeting mission, and it keeps us honest and it keeps us motivated. But the VA was in the news, CDC has been in the news, we've been in the news, and this just suggests, again, that our national leaders expect more of us. We are constantly under the microscope because of our mission and the people we serve. Our society has rededicated its commitment to servicemen and women who put their lives on the line for this nation, that they will receive the appropriate care and the appropriate benefits, and there will be no excuses for the delivery of that care. In June, Secretary Hagel asked us to do a 3-month review to ensure that we were transparent about our reporting and that we were, in fact, meeting standards as it relates to access, quality, and safety. Senior internal leaders from each of the services, Army, Navy, and Air Force, managed this review process, and we left no stone unturned. We produced a report that is quite extensive, some 600 plus pages, and we invited external reviewers to be part of this review. Some of the leading experts in the country on quality and safety. They provided invaluable and unvarnished opinions on what we were doing, what was right and what was wrong. And we've printed their full statement, and it's out there for anybody who cares to read it. So here are the big takeaways from that review. And I'll try and characterize or paraphrase it from the point of view of one of our reviewers, Peter Provenost, who was from Hopkins. He essentially said that you wanted to prove that you were comparable to American medicine. And congratulations, you proved that, you are. Unfortunately, all American medicine needs a lot more work around quality and safety. So although we don't view ourselves as outliers from the mainstream American medicine, that's not our aspirational goal, to be average and comparable. This gets us back to where our national leaders are at in our expectations for the military health system, that where there are gaps in knowledge about service delivery or methods for treatment, that we will close those gaps and we will be ahead of the curve. And so we need to be mindful of that. And our review showed that we are very comparable, but that's not where we want to be. So there's work to do. There are some things that were found also, that we did have variability across our system, true in the civilian sector, true in our system. We needed to come up with more common metrics that we can measure ourselves internally against and then drive ourselves to those achievable goals of better outcomes. And then we needed to ensure greater transparency. And it wasn't about just the data. It was about putting data out there that was consumable by our stakeholders in a way in which it was meaningful. And that's what we're working on now, so that our beneficiaries, in fact, can look at the data and say, if I'm in North Carolina and I want to go to the Army Hospital in North Carolina, how does the Army Hospital in North Carolina compare to local hospitals? What's relevant to me? Now, last spring, of course, as I said, part of that critical review, there were a couple of articles that came out in the New York Times. And for the record, I want to state that we're not taking any issue with what was printed. In fact, we sat down and met with the Times reporter. We provided information to them under the Freedom of Information Act. It was essentially our data, and we understood where we were going because we started this process long before the reporter got interested in these activities. And I think it was, in fact, part of our own self-analytic issues that sparked some interest. Some 3.5 years ago, I sat down with our leaders and said I wanted to make our system the safest healthcare system in the world, and we began to set about understanding what we were doing and putting processes and measures in place. So no problem, essentially, what was written. However, what didn't come across, I think, in the articles was context. The context illustrates the complexity of the healthcare delivery system and really where we were. So the articles looked at certain issues of surgical morbidity and mortality and perinatal indicators, but let's go through those and look at those with a few examples. So this slide looks at our perinatal care issues. One of the contextual issues that you need to understand is that we decided some time ago that we were going to compare ourselves with the most aggressive systems in the country relative to quality and safety. And so one of the context issues is that you can say that, in fact, the data showed that we were better in perinatal mortality and certain other outcomes, and maybe in peripartum hemorrhage, we were a little bit lower than the other institutions we were comparing ourselves to. But the fact of the matter is that there are only 85 hospitals of 5,000 hospitals in the country that actually participate in this database. So it's a very select group of hospitals that we're comparing to ourselves to. And I don't want, again, anybody to think that this is an excuse. It just means that the state of play suggests that there are some committed and then there are others. We're part of the committed pool, and we're part of identifying to ourselves and everyone what our data is and then making progress. But this is an important context issue. Certain other things can be said about, cesarean section above average, mortality outcomes above average, but clearly some areas to improve in terms of helping to define what really birth trauma is and then measuring that. One of the things we have committed to do is reporting every event, so we are a lot more disciplined about reporting our outcomes than a number of other institutions. Surgical quality was also examined. And we have a similar story to tell there, that in some indicators we're above average, in other indicators we might need to do a little bit more work. In order to achieve, though, where we want to go, it's important to understand your results. Define what is your end state and develop a roadmap or lines of effort or a pathway to get there, ensuring along the way that you have measurements that accurately define what it is you're doing and demonstrate that you're making progress. And so this then becomes the rest of the story. We started some time ago with our leadership to define our strategy of the military health system. And for, again, those of you who are new to our system, historically we had an Army system, a Navy system, and an Air Force medical system. Yet, as I mentioned early in this talk, the complexities of healthcare, the technology, the subspecialties, et cetera, require us to redefine ourselves as the military health system and develop some common business processes, clinical processes, administrative processes that return value to not only our beneficiaries but to the American public. Dr. Clancy already introduced you to the triple aim, which is a basis upon which many healthcare systems, high-quality healthcare systems, strive for or identify as their pillars, which include better health, better care, and lower costs. And because if you look at that, that really is a value statement. If you can deliver better care, produce better health at a lower cost, that's a value statement. Cost doesn't need to be the major focus, but it should be one of the outcomes. It should be a motivator, but it really is about better care and better health. And if you can deliver on better health and better care at lower cost, that's a true value statement. But in the military health system, again, based upon all that I have described to you about our importance in the national defense and national security strategy, we needed to include a fourth aim, which was improved readiness, because if you look at our mission and vision, it really is about being in support of national security and supporting the warfighter requirements anywhere we're asked to go in the world, and we need to keep that up front. So the quadruple aim remains our strategic framework or our true north, but the strategy map also shows how we can create value. And it reads from bottom to top, showing how we build an organizational capability to excel in the processes that are critical to our success in accomplishing the quadruple aim of improved readiness, better health, better care at lower cost. It also reads from right to left, because we know that providing better care, we can improve the health of all of our patients and contribute to the ultimate goal of the readiness of the force, which includes our families. So our vision is a fully integrated system that has the unique capability to accomplish the quadruple aim, support the Department of Defense and the national security. The strategy map communicates to all stakeholders the ends, ways, and means of achieving these goals, and is an accountability tool. Now, it's very important to understand that this business of the quadruple aim took a lot of thought. And when we introduced it at the Institute of Medicine, they said you may be on to something by adding that fourth aim of readiness. And they said for the rest of the country, we need to interpret that in terms of the ability of the workforce to engage in the process of producing healthier outcomes and better quality and value, but also ensuring that the patients and beneficiaries are able to participate as true partners in better health and better outcome. And they're thinking about adding that fourth aim to the triple aim. Now, as we go forward, I want to build the slide a little bit. I'm not a fan of complicated slides, but I want to ensure that we have a takeaway for everybody in the audience, no matter where you're coming from. The foundation of our success is organizational capability. We will support the services and defining and training, of course, helping to train the total medical force. And this includes our active duty providers of all stripes, our reserve component, and our civilian contributors as well, which are very important. Over the next several years, will be implementing a comprehensive electronic record, so we're going to be giving them the tools. We've taken an honest look at ourselves in terms of modernization, and it's asking the question about how best and where do we locate hospitals, clinics, and how do we, in fact, create a new system of distributive care, so-called invading the white space, if you will, of where our beneficiaries live, work, and play to influence positive health outcomes, so that we deliver the right care in the right place at the right time to the right people to produce the high quality outcomes. This is a major, major change in the way we think about delivering care. In total, this is a coordinated set of improvements to our organizational capability that will modernize our enterprise management strategy. The important takeaway is this: we are going to spend our money and direct our people toward the things in our strategy that matter, and make sure that we have the right infrastructure in the right places, both physical plant, information technology infrastructure, as well as leader development. If we go ahead and build, at the center of our strategy, of course, is readiness. And so this is really important. This is about producing a medically ready force that is healthy individuals that can go and defend this nation, and a ready medical force, which are all of you, the healthcare providers, the enablers of the military health system. In order to do this, we need to ensure that we have enhanced strategic partnerships. We talked about during the interwar years how we, in fact, feed off of the civilian sector. But this is about partnerships in many, many different areas: research and development, academics, industry, federal partners, very important, and international partners as well. And so this is about strengthening our capability to improve our ability to reach around the globe, to deliver services in support of men and women who go in harm's way, but in support of operations, our global diplomacy strategy, our global international partnership agreements as well. And so I'm going to take just a couple of minutes to go a little bit deeper in this in just a second. Better care and better health are ends in its own right, but it also contributes to readiness. We've talked about the fact that part of our mission is to deliver an insurance program, and so we needed to reform TRICARE that, in fact, would achieve the same ends of better health and better care. And this is about now connecting with and influencing the civilian sector to meet our needs, our imperatives, and our ends. It is about focusing on the outcomes that matter to patients, and so this is really important. And as a result, we need to expand the boundaries of healthcare so, as I said before, we can influence healthcare and health outcomes in places where people live, work, and play. Even though we intend to shift our focus from healthcare to health, it's very important that in order to ensure safe, high-quality care that gets the outcomes we need to align the incentives to reward value over volume of care and use transparent performance metrics and a management system that communicates to all of our stakeholders exactly what we're doing. And here's an important issue that by creating the transparency and getting the feedback, the appropriate feedback, that's an important part of improving the system. So it's about working with our advocacy groups, the veteran service organizations, to ensure that their input, as they represent the group we purport to serve, we can understand what their needs are and how best to serve them. It's about creating a high reliability organization, which is defined by the fact that everybody understands the strategic direction, everybody understands their part to play in creating high-quality, patient-safe care from whatever position or foxhole they may play within that organization. They support, their efforts are nested in the grand scheme. Part of our initiative then has been to transform primary care, utilizing the patient-centered medical home model as the anchor by which we will develop better strategies for care and better outcomes. And all of this is going to be done in the light of day, as I said, with measurement that is transparent to all of our stakeholders. Higher value, not just lower cost, is our primary goal. But we know that to create value, we must do things right the first time, every time, eliminate waste, and more effectively apply our resources. This is about stewardship, no doubt. We're going to reform TRICARE by aligning these incentives and bringing greater value in terms of the dollars we spend in the private sector. And by the way, 70% of those dollars are spent in the private sector. Eliminate things like waste and wait times, duplicate visits, by the ability to reach into that white space. Improve safety and improve the comprehensiveness of primary care. So this is our strategy map. It looks complicated, but there are a lot of actors in the system, a lot of parts to play, but it is a unifying concept that everyone can understand about how we're driving forward to improve our system. There are internal processes, there are organizational capabilities that are spelled out, there are patient, leader, and stakeholder accountability issues that will result in the ends we desire. The military health system strategy, as I said, is a complicated roadmap, but there are some elements that bear further highlights. In our current culture, we need to be committed to zero harm. It's an aspirational goal, but it's an achievable goal. And I've been around the country at different medical centers where they've had remarkable success in hospital-acquired infections and safety in the operating room. And we need to be replicating those outcomes and those best practices. In order to do this, though, we need a patient population that's more engaged. And so that is an important element as we go forward. Readiness remains at our center. Engaged patients and transparent information are going to be some of our cornerstones going forward. Let me give you the elevator speech on this, though. So that's a very complicated map, and if you take away nothing from this talk, I want you to understand that we're going to be moving down 6 important strategic lines of effort. Modernizing our management with an enterprise focus, defining our 21st century capabilities and manpower, investing in and expanding our strategic partnerships, assessing the balance of the medical force structure, modernizing the TRICARE program, and defining the MHS goal and health engagements around the globe. remember that health engagement now really is a new instrument of national power. A couple of words about modernizing management, though. We've started down this road with great success already. Later this morning, you're going to be hearing from Lieutenant General Robb about the development of the Defense Health Agency, with the important initial 10 shared services of facilities management, medical logistics, health information technology, TRICARE management, pharmacy management, public health, acquisitions and contracting, budget and resource management, medical education and training, and research and development. Very important core business processes in which we can achieve higher qualities with economies of scale at reduced cost. We have another aligned strategy which looks at our so-called multi-service markets. And for those of you who are not familiar with these terms, around the country we have different areas in where we provide services to both active duty and beneficiaries, and we have military treatment facilities located. Our job in the future is to combine the efforts of the kind of care we deliver in this direct care system, that is those military treatment centers, and optimize our use, if you will, of the purchase care system so that we don't have underutilized military treatment facilities and spend a lot of money in the purchase care market. So this new combined strategy brings into sharp focus the support of our direct care system, even as we optimize the dollars we spend in the purchase care system. Again, this gets back to the value equation. All of this will lead us to a better, stronger, more relevant system for the future. And you must remember that relevancy here is defined by your value, because right now, last night, the NDA, the National Defense Authorization Act, was approved. That tells us what we can spend money on. The dollar value of that, the core budget for that, is about $495 billion. It goes about to $580 billion when you have some add-ons, but the core budget is about $495 billion. Right now, the military health system is about $50 billion in cost. So we're about 10% of the Department of Defense budget. And as the top line of the Department of Defense budget comes down, if we don't reform and produce better value, we compete with the combat arms to train, man, equip, and modernize their force. And we become a detractor in terms of that national defense and national security strategy if we don't do our job correctly. Important to this, of course, is defining new 21st century capabilities. And I'm not going to go into this detail, but it is about producing new enabling technologies such as a modern electronic health record, which provides decision support, provides a lot of tools that assist in analyzing our business and analyzing our outcomes and what we need for our patients to develop better strategies for care. We intend to begin fielding this new electronic record actually in the fourth quarter of FY16. So we need to look at the value of technology and innovation going forward. The EHR is one, but medical simulation is another. Telehealth is going to be an important tool that we are going to develop within our enterprise because it gives us the ability to reach forward and reach back. As mentioned before, we're a highly distributed military health system around the world, and the providers on the front line are expected to deliver above the standard of care. They can only do that if they can reach back and get the important consultation and assistance of technology that we might have in garrison back here in the United States. So this is important for us to develop, and develop it as a system, not just a technology, a system that is fully integrated into the way we deliver care so we get maximum value out of it. So there are opportunities here. Want to highlight the issue of partnerships, strategic partnerships. In the federal space, Dr. Clancy and I are working together and her predecessor, Dr. Petzel, we forged new ground in terms of our cooperation together and what we do in common clinical processes and business processes to eliminate waste. Between the Veterans Administration and the military health system, we have about 211 hospitals. It costs about $500 million to replace a hospital. The American taxpayer is not, in the future, going to fund that bill unless they know they're getting value out of it and they ensure that, in fact, we have eliminated waste and we are delivering the right services in the right place at the right time for this entire population that we must serve. So we must work together. But it's also about working with the public health system. You heard about that. With CDC, as we're working with them to respond to the Ebola crisis. FDA, the Centers for Medicaid and Medicare Services, academia, industry, and of course, other professional societies like AMSUS and the American College of Surgeons that is featured in this slide, where I recently signed a partnership agreement with them to further advance the issue about surgical quality and trauma care. I'm going to sum up here pretty quickly, but the issue for us also is about redefining and defining the new 21st century core competencies. Featured prominently in this group of capabilities is our ability to globally engage from a health point of view. As I mentioned before, it's a new instrument of national power that serves not only this nation well, but serves other nations around the world very well in terms of their own security, as we hope to partner with other nations and partner with host nations to build capabilities to detect emerging infectious diseases and build public health capability that will ensure the safety of the world's human population. So good news, we've been really driving this home for the last 3 years, and we've got a great deal of interest in interagency, that is U.S. government interagency, acknowledgement of the importance of this, even before this Ebola crisis hit. And in fact, we relied on some of our connections during the Ebola crisis to help, in fact, streamline and develop more quickly the responses that we need. This is our future, collectively, nationally and internationally, and so global health engagement is going to be extraordinarily important. We talked a little bit about this Ebola. There are lots of lessons to learn, and I know there are sessions today that will, in fact, get into the nuances of how our response has gone. But the issue really is about people. It's very central to what we do in medicine. We are a military health system, but we are about caring for people, not only our people, but people around the world. So let me sum up with this last slide here. This is really an exciting time to be part of the military health system. So for all of you folks out there in uniform, get ready. This train is going to move extraordinarily fast, and you are part of it. Understand what we're all about. For our international partners, I hope to be talking with you today at the lunch, but there's a lot of exciting things that we can do together around the world as well that are complementary and beneficial to all of our countries. We know what happened on September 11th, 2001, and we know what sort of challenges have come out of that. We understand the complicated world that we are involved with. We just need to get energized to find the new solutions to the challenges of the 21st century. The world will remain volatile, uncertain, and complex. But as senior leaders, as strategic leaders, we need to rise to the occasion and be energized to find those solutions. Partnerships, very important. Federal, state, military to military, international, civilian partnerships are the way to that successful end in the future and a better world. So thank you very much for listening to me today, and I think we may have time for 1 or 2 questions. Thank you.
there's any
Yes.
questions, I have a mic.
Dr. Woodson, thank you very much for your presentation. My question and request stems around the future of really multinational or coalition responses, no longer just to the kinetic environment, but really to any threat that we face, with Ebola on the forefront being a excellent example. What I'm looking for from our senior leaders across all nations is this construct of coalition from the get-go when we get
I'm
involved.
sorry, could you say that again?
A coalition from the beginning, a coalition from the get-go, which is to say, especially in a permissive environment, that is, there's no kinetic threat, the sustainment requirements in the field don't have to be as large. When we were in Afghanistan, we had different countries take the lead in different regions, and as a result, if you were in RC North, it was the Germans, the Bundeswehr, who were providing a bunch of the support. Other people could tie into that. That same concept should apply wherever we respond in the world, but we need to have that kind of paradigm set so that when I'm on the ground in Liberia and I get the Swiss or the Germans or the French and the UK come and say, Jim, can we use your role too? Can we use your part of our medevac so when we contribute, we don't have to bring the same? There should be a methodology to do that from the get-go, and that's what I would look for.
Yeah, thank you for that question. And I think if the audience didn't hear all of it, I think it's centered around how do we build coalitions from the beginning and better working partnerships so that whatever mission comes down the road, we are better organized and prepared to respond. Did I capture it correctly? Yeah, and so I couldn't agree with you more, and that's exactly why we have defined global health engagement as an important issue for us to deal with in terms of understanding our requirements and our competencies. Because as we have dealt with Ebola and other events, we know that we need to understand how our partner nations work, what equipment they have, their strategies for delivering care. We need to understand what the host nation environment will permit, not only from a technological point of view, but from a cultural point of view, so that we can get the best outcomes. The important issue here is that this will be a journey, and that it's a journey of discovery about how to do this better. We will always face situations in which we will have to put in place just-in-time plans, but if we understand the elements that we need to consider, we will be much more successful about putting together these coalitions to meet whatever mission might come down the road. So that's the best way of framing it at this point. Other questions?
There's only one of me, so if you have questions. All right, we'll get this one here.
Good morning, sir. Kristen Beals. I work at Wilford Hall in San Antonio, Texas. I'm interested to see what the marketing message is going to be when you mention we need to focus on value over volume. Because historically, the only thing, as I've been working in clinics and then talking to everyone, and we've only been focused on business plans and productivity and RVUs, and that's how we get resourced, you know, from the top down. So how are you going to measure value? Is that going to be patient-centered value, or what are those measurements going to be, and what message are you going to send to the military treatment facilities in order to focus on value over volume?
Yeah, excellent question. And of course, I think as we mature in our understanding of healthcare delivery systems, this issue of quality and this issue of value, here's where we need to go. Initially, it was about cost per unit, and that's where you get RVUs from. A very inexact, rough way of looking at what you're providing for X amount of dollars. what we're moving toward now is better defining the outcomes. And the outcomes need to be defined not only from our perspective as the administrators of the system or the healthcare providers, but this is why it's very important to get the patients and our beneficiaries involved in defining the outcomes that they desire. Let me just say for the record that this is really achievable if we, in fact, redesign the system. So many of you know that I'm a vascular surgeon, and so I loved to operate, do complex operations. And I would have people come back to my office all the time for their little wound check, right? But the daughter of the patient had to take time off from work and kind of come in the office and sit there until I was available. And if I got tied up in the operating room, they sat there and they wasted their time. Well, in a new system where we deliver care where they live, work, and play, with telehealth, basically, I can do the wound check probably over the internet. The daughter doesn't have to take time off from work. We could probably reduce hospital staff, et cetera. I don't want that to sound like the answer. What I'm just trying to do is give you an example that if we think creatively, we can get to the desired outcomes at lower cost, and that's where the value comes into play. And we can get away from these rough early metrics that didn't really give us what we needed. I hope that answered the question.
Hi, Dr. Woodson. I was in the Navy for 20 years. When I left the Navy, I have an awakening regarding integrative health. Is there any possibility that military health, when it comes to chronic illness, emphasizes lifestyle, wellness, and reimbursement and incentives for physicians, like in a staff model, becomes more of a focus on acute trauma cost and allow families that have chronic illness, allow the military and active duty with chronic illness to not rely on a pill for every ill? Any movement on that?
Can you restate the last part of it? I'm having a little trouble.
Oh, and we have a medical model that it emphasizes disease model versus healthcare model, peacetime or wartime. So to get the troops ready to deploy with chronic illness is not the same when you have to take a pill for every ill, whether it's chronic pain or others.
Yeah, no, excellent question. But I think this also talks to the issue of how we need to redesign our delivery, our healthcare delivery, not based upon treatment of sick established problems, but moving from a system of healthcare which addresses the treatment of established, usually preventable problems, to one of health, where we talk about how do we how do we get our patients involved in healthy behaviors, how do we get them involved with understanding how best to utilize the system so it's not a pill for every ill. If you noticed in the talk, I kept coming back to the issue about the involvement of patients or our beneficiaries. Very, very important in this process of going forward. In the military health system, we basically begin with a healthy population, right? Young people who join the service. It should be our job to keep them healthy and keep them oriented and focused on preserving their health throughout their tenure, and this should carry on into their retired status. So there's a lot of work to be done in many elements of what we do, not only in terms of the provider orientation, but also involving our patients as well.
Dr. Woodson, sir, it's Captain Steve Bree, the British Liaison Officer from the UK. Just want to pick up on one of your lines of effort you talked about. As you know, in the UK...
Excuse me, can I ask you to do me a favor and come forward? There's really an echo here, and up here I cannot hear your question. So if maybe you can tell me the question and I'll repeat it back to the audience. Okay.
Sir, it's Steve Bree, the British Liaison Officer from the UK.
Yes, hi.
One of your lines of effort you talked about was collaboration in the future. And as you know, in the UK, we've gone heavily across the NHS for our care for our troops. Where do you see the meat on the bone for collaboration with the DoD and outside facilities in the future?
Yeah. Well, listen, I think there's great opportunity. The question was about where do we see collaboration going between sort of partner nations and military. Well, as you know, the U.S. has had a presence on the European continent for some time, and there's a lot of discussion about where that's going. But let's just use the example of UK. Right now, we have partnership agreements, let's say, in Lakenheath, where we are, in fact, partnering with the UK to not only deliver care to our beneficiaries in our facilities, but deliver care in your facilities. There are just a great deal of opportunities to partner as we better understand how our systems are set up to deliver care. But most importantly, it's about also being prepared to engage as partners in whatever event occurs in the world, you know, in a year or 2 years down the road. We have learned this as being very important, and of course, coming out of the Afghanistan and Iraq events, where we had coalition hospitals. Many of you, there's no reason why you should know this, but I can remember back when we were in the Balkans back in the late 1990s and 2000s, where we tried to build, literally build the first coalition hospital, how much difficulty we had in just calling the same thing by a common name. I think what we do during the interwar years in terms of establishing our understanding about healthcare delivery, treatment strategies is going to go a long way so that we can, in fact, partner together during operations. We've had, you know, great interactions with the UK and a number of other medical forces, Germany and many others. So the key is to further these partnerships.
Okay, we think we have another one or two. Well, sorry for the walk.
No problem.
Oh, okay, yeah. Yeah, Dr. Scott from Tampa. The MEB-PB process still seems to be a long process for seriously ill people to work through the medical disability exams and that to get into the VA. And I know we've tried a number of ways, you know, combining the two agencies and that, but it still seems like it's a long process. Many of the patients that we have seriously ill have to go back to Wounded Warrior units and stay months at times before they could be processed out. Is there ways that we could, or is there some strategic plan to try to speed that process up?
Yeah, good question. The question relates to the medical disability evaluation system, the medical evaluation boards, the physical evaluation boards, and the whole process that we go through here in the United States so that if a service member becomes ill or injured, they are evaluated and then processed to veteran status and are accorded the benefits that they deserve and should acquire. And the question that is being asked is, it's been cumbersome, it's been criticized, and what can we do? The key thing for us to understand is that, and this gets back to the Deming principle. Anybody know about Edward Deming and what he talked about? He was a guru of quality management. He said, every organization is perfectly designed to get the results that it gets. And with the disability evaluation system, it was designed decades ago to process off of active duty millions of service members who had to transition to veteran status that had become ill or injured. And the way you did that is that if you could no longer carry that rifle, you were said, okay, medically you could no longer carry that rifle, and you were given to the Veterans Administration to do the processing. Fast forward, As I said before, the expectations of our national leaders and the expectations of our beneficiaries, and therefore our expectations are radically different. We now have a professional force. We don't have a conscripted force. They see themselves as full-time career servicemen and women. One of the things you cannot do is just say, you are not fit for service, go to the VA and get your benefits. That doesn't work anymore. What we have now is a responsibility for a thorough and efficient evaluation that says, okay, these are now your medical conditions. Can you serve, continue to serve? And remember, we have 25% of amputees stay on active duty today, okay, just as an illustration of the change in thought process. Can you still stay in the service, or do you need to be retired to veteran status? Now, that's a complicated interaction of not only documentation, medical documentation and administrative documentation, and agreement by the individual. There's an appeal process. And all of this comes together and has been thrown into an archaic system that wasn't designed for what it's supposed to do today. So the short answer is yes, we need to redesign the system, and we have been progressively redesigning the system. Just 2 days ago, I looked at some new data. We had set for ourselves a goal of 295 days to get folks through the system. It gives enough time for evaluation and appeals, et cetera. We're at 299 days. That doesn't mean we should raise our hands up and say success. There's a lot of other processes that we need to redesign. So my commitment to you is that we are going to continue to work this process to redesign it, but it's got to be designed so it's fair to the transitioning service member as well.
We've got one last one.
Dr. Woodson, Dr. Jeffries, Navy retired. The question is in the aspect of one of the new diseases, but a cofactor of significance for a long time, and that's overweight and obesity. And as you know, the problem is lifestyle isn't just getting more physical fitness and diet, but it has to do with mindfulness, it has to do with emotions and everything else about it. Mm-hmm. And it's a main precursor of a lot of our chronic diseases and our healthcare cost. And yet in the short term, it's very costly in changing those things. The outcomes are later. And you're in a cost reduction situation right now. How are you going to address that if we're really going to go to get the healthy, not only military force, but our families and the nation?
Thank you very much for that question. And the question addresses, look, we got it, you're trying to make reforms, but really part of the issue is changing behaviors. And that's why we've begun to focus on the issue of moving from healthcare to health. Where healthcare is about providing care for those diseases that an individual has already accrued, and most of them are preventable. That is why, in fact, you heard from Captain Ellenberg yesterday how we're really ramping up our issues to disincentivize the use of tobacco problems, a major contributor to preventable disease. But it's also why you heard me speak about the issue about moving into the white space where people live, work, and play, so that we can influence their behaviors relative to their health and give them the tools, the opportunity to make the healthy choice the right choice. We have designed and implemented a Healthy Base Initiative where we do an entire environmental scan of the installation and target projects that will improve the health of the environment so that people can bike to work, that their gyms are available, that the cafeterias have more healthier options that are readily identifiable by sort of a red, yellow, green color coding. By moving into the commissaries to try and hide those cigarettes, the Joint Chiefs have just given a thumbs up on a number of initiatives that we're not quite ready to announce publicly, but we will very soon, that addresses many more of these environmental issues relative to tobacco. So what I'm saying to you is that it requires a sustained leadership focus, not just medical leadership focus. This requires the investment of line leaders, advocacy groups, patient leadership groups to understand how we need to move not only as a military but a nation from one of healthcare to health and decreasing the preventative the causes of preventative of disease. One of the things we've subscribed to is the National Prevention Strategy, which is our collaboration with the private sector around these public health measures to decrease the preventable causes of chronic disease. So we're working on it. It's going to be, it's not going to be tomorrow we'll solve it, but it's iterative. So I think we're out of time, right? Is that correct?
Absolutely, yes, sir.
Thank you so much for your time and your attention.
A round of applause for both of our speakers this morning. Thank you so much. Terrific.